The theme of this week's news is we have a disconnect from what we can do in infectious disease from actually what we're doing. And I think that really speaks to how effective the tools we have are, especially vaccines, but how ineffective our policy is in the face of declining trust, policy instability, and overt disinformation that comes from some of the highest levels of government. And at the same time that all this is occurring, infectious diseases continue to threaten us. They're not going away, and some of those threats are increasing. Again, we're not losing to infectious diseases because of the biology of infectious diseases. We're losing it because of the philosophy of some of our policymakers when it comes to infectious diseases, and some of the philosophies of those people in the public who evade what the threat of infectious disease means. So the central story of this week is the same as it was last week. It's really vaccines under pressure. There was a poll, and that poll has sort of since been debunked because of the way the questions were asked, but it kind of spoke to something that many of us are afraid of, is that our vaccine or anti-vaccine views, are they no longer fringe? Are they becoming mainstream? Do more and more people doubt the value of vaccines? Do they deny the benefits of vaccines? And I think that's a scary prospect. And that poll that Politico put out kind of illustrated that. But again, they asked the questions in a way that certain people might have been forced to answer certain ways, and it might have overestimated that sentiment. But I think the concern still remains regardless. And RFK Jr. testified in Congress this week, and he did his overt lying. One particular favorite of mine was when he said that he's not anti-vaccine.
The doctor who gives this vaccine to a child is committing medical malpractice.
We should not be giving black people the same vaccine schedule that's given to whites.
I do believe that autism does come from vaccines.
This is a person who has spent decades spreading disinformation about vaccines, who says he wants to erect a statue to Andrew Wakefield, the man who perpetrated the fraud that tried to link the MMR vaccine with autism. So for him to say that he's not that he's never been anti-vaccine is just him lying as usual. He also stated that the MMR vaccine is safe and effective. So he'll say anything, I think, to stay in power, because he clearly has undermined the MMR vaccine. Because if you want to undermine the MMR vaccine, one way to do it is to say, I want to build a statue to Andrew Wakefield. And that's what he's done. He's also stated, oh, well, the measles outbreaks that are occurring in the United States, they started before I became HHS secretary, before my swearing in date. As if the work he did for the 2 decades prior had nothing to do with anti-vaccine sentiment in this country. So to me, this is just mind-boggling. And that's why I expressed concerns in multiple media outlets this week about the new CDC director nominee, Dr. Schwartz, who is eminently qualified, a major figure in public health for decades at the Coast Guard, worked on biological weapons policy, worked on COVID policy. Is she going to have to answer to RFK Jr.? I think it's truly beneath any doctor to try to answer to RFK Jr. But how do we prevent the same type of events that occurred and led to Dr. Menarez's firing from occurring to Dr. Schwartz? And I think that that's the concern. So this is all kind of window dressing, nominating this slate of people for CDC when you still have RFK Jr. in control of HHS. So I think that's the paradox. These are opposing worldviews. Dr. Schwartz, pro-human; RFK Jr., anti-human. Dr. Schwartz, rational; Secretary Kennedy, irrational, nihilistic. And I think that when you look at what's happening, we have more and more outbreaks that are occurring. Herd immunity thresholds are being undermined. Places like Broward County, Florida, are in the 80s when it comes to protection with kindergarten slated vaccines. This is the lowest in the state of Florida. So I think this is kind of embarrassing, and it's actually the result of bad policy. And these policy decisions are directly shaping the outcomes. And it's all a self-inflicted public health problem. This isn't some kind of access issue. This is really a disinformation problem. We have the tools, we're just not using them effectively. I wanted to just talk about a few specific policies that are occurring. There are bills in place to try and lessen daycare requirements. So if a kid goes to daycare, there are certain vaccines they need to have. There are efforts to undermine even those. So they didn't stop at just the schools. They're now going to daycares. And as I've always said, organizations have the right to set their own vaccination policy. The government should not be intervening to decrease them because of political pandering. And that's what's happening. In West Virginia, they're trying to get rid of the ban on religious exemptions. West Virginia is one of the states that had very high vaccination rates, partly because of the fact that they have no philosophical and religious exemptions. Now they're suing to get rid of that policy, and one of the federal appeals courts has not allowed that to happen. But again, this is real policy work that's happening. They're trying to add basically fabricated injuries to the vaccine injury table. This is being done by RFK Jr.'s former personal attorney. So this is all really coming to a fore here. And at the same time that I'm talking about all of these endemic respiratory and childhood diseases that I'm worried about, avian influenza's threat continues to loom, not just from H5N1, but from other avian viruses like H9N2. So H9N2, for example, more cases occurred in China. There clearly is an uptick in China and mainland China from 2026 to over 2025. Unclear why that's occurring. We saw a case in Italy in a traveler from Senegal. Not clear how this person got infected. That's concerning. More H5N1 outbreaks are occurring in dairy cattle farms in the United States, including in Wisconsin. How many of those dairy workers were tested to see if they had infection as well? I don't know. I suspect it's not a very high number. We have massive ongoing gaps in human surveillance for bird flu, which, as I've always said, is the biggest pandemic threat that we face. And the more of this gap that we have, the more the virus has the chance to adapt to mammals, adapt to humans, and more early warning signs are accumulating. You can imagine what the early warning signs might have been for 1918. We didn't have the technology to actually look for those. Now we do, but we're not using that technology. And I think this is, this is a slow building story of just ignoring warning signals. And then when something happens, when the inevitable bird flu pandemic starts, people will say, oh, this is a conspiracy because all of these people were talking about it and saying it, so they must have created it, which is sort of what happened with COVID. But the fact that we were warning about coronavirus pandemics, then when one occurred, then you get not credit for being prescient, but you get put in the National Enquirer like I did. I wanted to move to some diseases that still are major problems that we haven't quite solved all the issues for. So tuberculosis. Remember, tuberculosis is the #1 infectious disease killer of humans in 2026. And there's about 10,000 cases that occur in the United States. We have major diagnostic gaps there. We don't know who is infected. We don't catch all these people with latent tuberculosis, and then active tuberculosis occurs. We have a vaccine that's not the best vaccine. There are other vaccines that are in clinical trials. Again, probably not showing great efficacy at preventing latent tuberculosis, which is kind of the sleeping tuberculosis that they used to test for with the skin test, or pulmonary tuberculosis in the lungs. What we need is a vaccine that can do that. Other studies show that when we do testing for tuberculosis, for active tuberculosis on people's sputum, they cough up that phlegm and we test it. We do some sophisticated tests, some not so sophisticated tests. We're probably missing cases because when they look with very sensitive DNA tests, they do find tuberculosis there in the United States in patients who don't culture positive, whose standard testing is negative. So what burden do they present to the overall tuberculosis burden? What is their risk of activation? How contagious are they? All of those are important questions to mention. HIV, again, the issue here is that we still are not stopping new infections. There are really great tools. Those tools need to be implemented, and we have to implement those tools in a way that doesn't destroy the fountainhead of those tools, which are pharmaceutical companies like Gilead. And I think we're starting to see them being used in parts of Africa in the high impact areas, which makes sense. Where is it going to make the biggest benefit to give this drug, which is a shot every 6 months that makes people impervious to HIV infection? How do you find the high risk people? How do you not waste the supply? How do you use it where it's going to really make a dent? And there's also work on cure. For example, trying to find methods to get people off of HIV medications. Right now, they're on HIV medications for life, but is there a way to use a combination of innovative vaccine approaches like DNA vaccines, as well as broadly neutralizing monoclonal antibodies to be able to get people off of therapy. And there's work going on in San Francisco that's showing at least proof of concept that they're moving forward on HIV cure research as well. Malaria, the other of the big three. This is, we just had past World Malaria Day. You remember malaria kills around 600,000 people every year. Half of all humans that have ever lived are said to have died of malaria. We do have malaria vaccines, 2 malaria vaccines, not the greatest efficacy, but they have a non-zero efficacy, and they're part of a layered structured program, including insecticide bedside nets, genetically modified mosquitoes, which is my favorite, malaria drugs. All of that is part of a layered containment strategy to try and remove malaria. And many countries have eliminated malaria, but a lot of work needs to be done. That vaccine rollout is probably not happening fast enough, and it will cut the number of malaria deaths. We've already seen that in data, and that's something that needs to happen. And these diseases are persisting despite existing tools. Again, this is about being serious about infectious disease, recognizing that the control of infectious disease is a civilizing force, that it makes everyone's life better when people are flourishing all over the world. And in some of these countries where malaria, tuberculosis, and HIV are still major public health problems, major disruptors of life, they hold those people back. They hold those countries back. They hold human innovation back. So we really need to get into the idea of implementing these to the highest degree possible while respecting the fact that they do come from pharmaceutical companies. And it's important that pharmaceutical companies are rewarded for these innovations. Last, I want to move to some emerging and some uncertain signals. I think number one is this mystery disease in Burundi. Burundi is a landlocked country in the Great Lakes region of Africa. There is a cluster of people, about a dozen or so, with a case fatality ratio of about 14% of an unknown disease that causes fever, vomiting, diarrhea, jaundice, and they've tested for 200 different pathogens, including Ebola, Crimean Congo, hemorrhagic fever. They're testing animals like cattle and pigs, trying to figure out what's going on. I think this is going to be one to watch to understand what this might be. Is it infectious? Is it non-infectious? Is the first thing. The fact that they're having fever makes me think it is infectious, but it will be something that kind of evolves over time as we get more data. The fact that they tested for 200 things is really great. This is an example of proactive technology implementation in, not the United States, but in Burundi. So this is what you want to do. You want to look for all the bad things, all the common things before you, before you give up here. You want to actually get to the bottom of what's making these people sick. And it's going to be easier to contain this if it is communicable between person to person. But when you deal with it in a small place where there's only a small number of cases, rather than waiting for it to gain the ability to spread exponentially and spread across borders. So this is, I think, a good thing. Other interesting news, Lassa fever, another endemic disease, a viral hemorrhagic fever in West Africa. It also is associated with deafness and hearing problems. Again, this is another thing. So if Lassa fever is endemic in an area, people get Lassa fever, they survive, and they're left with hearing loss, that affects their future productivity, their future ability to flourish. This is why controlling these things has these cascading benefits. Dengue fever, just want to quickly mention Guillain-Barré syndrome. We think about Guillain-Barré syndrome with influenza, with Campylobacter bacterial infections, but dengue fever is also a risk for Guillain-Barré syndrome, especially in those first 2 weeks. Valley fever, it's a fungal disease. It's kind of centered, it's called Valley fever, the Central Valley of California, places like Fresno. This is a fungal disease. The spores are everywhere. They can get kicked up during dust storms. They can get kicked up with earthquakes. And there's many people that are exposed all the time. Most people do okay with it, but the number of cases over the last decades or so is increasing. Is that because of better diagnostic testing, better awareness, or an increase in the activity of this fungus? I think that remains to be seen, but this is an underrepresented or underappreciated fungal disease that's endemic in the United States. It does take a toll. A couple of other things I wanted to mention in the last part of this. One of the themes that I've been kind of harping on is the implementation of technology, and I think of vaccines as technology. That implementation is something that we want to encourage, especially in the high-risk groups. So, for example, with RSV, major mortality reductions are likely to occur with RSV vaccines increasing in the elderly population, but they're not vaccinated. HPV, cervical cancer, head and neck cancer, cancers of men, uptake low, but that technology has the ability to change those cancers forever. Influenza, not just something that makes flu less severe, but cardiovascular protection, less heart attacks, less strokes because of the inflammatory cascade that occurs with a severe influenza. The same is true for shingles, less stroke risk as well. When you get shingles, it increases inflammation. People are more likely in the week or so after getting shingles to have a stroke. The shingles vaccine stops that from occurring. But what we see is not people clamoring for these, but continued underutilization. The science here is not the limiting factor, it's the adoption and the perceptions people have. And we have this kind of widening gap, especially with things like HPV, between real world performance and uptake. There's a gap there. There shouldn't be a gap there. If something is a great piece of technology like an iPhone that has a great performance, there's not a real gap between uptake and performance, but there is for vaccines. So I think that's the paradox that we're dealing with. There's a lot of infectious disease that's invisible. Antimicrobial resistance is one of the most invisible things. People see it as a slow-moving public health threat. It's very abstract, but it's not abstract to an infectious disease doctor who has to be faced with an antibiotic-resistant infection for which they have no drug, or have to use a drug that's not the best, or have to craft together some kind of regimen that works. That's a real thing, and I think people don't really appreciate it. And these, the cutting edge of this are places like the neonatal ICU, transplant patients, burn patients. So we're getting better at using our antibiotics, but we still have this problem of antibiotic resistance that's a slow-moving, under-the-radar, invisible infectious disease threat. And what infectious disease doctors do, what microbiologists do, what infection control practitioners do, what anybody in the allied fields do, is often invisible and undervalued until it becomes a problem. And lastly, this week I did speak at my high school, and it was really heartening to talk to students that are interested and not cynical and have genuine questions about all of these problems in the world and infectious disease's role in them. And it's one of the most favorite things I do. And that kind of, if you get one student that gets interested in infectious disease and does something with that, I think that makes it all of it worth it. These types of talks that I give to students. But that's all I have for the week.